Good evening, and thanks for asking me to talk about amyloidosis. This is very near and dear to my heart and what I do all day long, every day at this point. Just to talk about some goals with this discussion, we're going to specifically look at how cardiac amyloidosis affects our patients and the importance of early recognition and diagnosis, understand the differences in presentation between men and women, and to specifically identify some diagnostic challenges in the female population. So we always talk about first, what is amyloidosis? And this is a piece of paper I give to all of my patients and fellows that come through our amyloid clinic, which is just kind of a breakdown. Amyloidosis is truthfully a group of diseases where proteins in the body misfold. When they misfold, they like to deposit systematically through lots of places in the body and can lead to a quite varied presentation, which often leads to diagnostic delay. So AL amyloidosis is a bone marrow problem where the bone marrow creates light chains, plasma cells, which create light chains. It is treated with chemotherapy. We do work very closely with our hematology colleagues on these patients, and we often end up right now still doing things like endomyocardial biopsy to get an urgent diagnosis. AA amyloidosis is a disease of inflammation where the treatment is really treatment of the underlying disease. And then TTR amyloidosis is the one that has gained a lot of traction in recent years because of easier diagnostics and the advent of treatment, which can make a big difference for our patients. The TTR protein is a protein made in the liver. I always tell patients it's like a four-leaf clover that falls apart into one-leaf clovers and deposits in lots of places. There's both wild type and hereditary. The wild type tends to, we think, occur more in men, though again, probably very underdiagnosed in our female population, and tends to occur more in Caucasians than others. The hereditary form is caused by a variant in the DNA, and there are at least 120 different DNA mutations that we know of that encode for the TTR protein. The hereditary form we feel is more often in women than the wild type, but still a very male predominant disease from what we know, though I think we're going to challenge some of that here today. So again, part of the reason that amyloidosis has been so challenging to diagnose is because it is so systemic. And we all know in modern medicine that there's challenges with people being very subspecialized, and there is one person who is taking care of the right pinky and another person who's taking care of the left nostril, and there's not often one person who puts those pieces of the puzzle together, and that leads to diagnostic delay. So what we like to talk about are red flag symptoms, which really can help people either on the inpatient side or the outpatient side kind of just have a couple of light bulbs that go off to think, could this potentially be amyloid, to pick up patients clinically? And that often is heart failure, plus carpal tunnel syndrome, orthostatic hypotension, GI problems like constipation or diarrhea. And what we're trying to do is leverage our electronic medical record system and artificial intelligence to help identify patients earlier and get them referred for earlier treatment as well. So this is important because what we know is that already we're winning. We're improving things for our patients. So we look at amyloid through a couple of different staging systems, one of which is called NAC staging from the National Amyloid Center. And these are biomarkers that help us prognosticate our patients. So the NAC staging system includes GFR and proBNP, and higher proBNP and a lower GFR portends a worse prognosis. So higher NAC stages tend to cause worse prognosis. And what we know is that through the last years, over the last 20 years, we've really started to diagnose more people at earlier stages, which is great for our patients because what we know is that when we diagnose them at earlier stages and get them treated, they do better and they live longer and have improved quality of life. So the goal here is early diagnosis again. So certainly, 10, 11 years ago, when I first came to my current institution, a lot of people said, well, what are you going to do about it, right? And we did not have a lot of treatments for TTR cardiac amyloidosis. Now, this is a a very busy slide, but I think it helps you see just the amazing advances that we've had over the last few years. So now we have 3 FDA-approved drugs just for the cardiac portion, as well as a few other drugs as well for neuropathy. So we can affect the disease in a couple of different ways. We can prevent the TTR protein from being made in the liver, and that's through gene editing. This is a clinical trial, the Magnitude trial, that's ongoing. There are 2 drugs that right now are FDA approved, patisiran and vutrisiran, for TTR knockdown, and those are, the vutrisiran is approved for cardiac manifestations. Eplontersen as well is another silencer that is approved for hereditary neuropathy. Then when we know that the liver makes the TTR protein as that 4-leaf clover, we can stabilize the 4-leaf clover with certain drugs called tafamidis, acoramidis, and there is some data off-label for diflunisal. Once that TTR tetramer has misfolded and formed amyloid fibrils that deposit in the tissue, now we're getting to the point that we're trying to actually cause reversal and remove amyloid fibrils. So we have 3 ongoing clinical trials where these drugs that are monoclonal antibodies actually potentially eat up the amyloid, phagocytose them, and cause reversal. So a lot of really good hope coming down the pipeline for our patients. And again, if people ever say, well, what's the point? There is a big point here, and that is we have a lot that we can do to help these patients. To show you how far we've come, these are our clinical trials over the last 10 years and how busy and active of a space this has become from a clinical trial perspective and how we've evolved all of our current therapies. Now, let's take a look at these trials. We're going to take a look at the 4 main trials that have led to the development of the drugs we discussed. So the ATTRACT trial examined tafamidis versus placebo. The ATTRibute trial was acoramidis versus placebo, so those are both stabilizers. And then the Apollo B and Helios B trial examined patisiran and vutrisiran, which are silencers that again prevent the TTR protein from being made, and versus placebo. In all of these trials, we see that the patients on average are in their mid to late 70s. And now let's look at the gender. Every single one of these trials are 88 to 91, 93% male predominant. So very few females included in these trials, which is really important when I'm sitting in clinic trying to tell a female to take one of these medications and trying to tell them that I know this will make them better, when very few females were even included in the trial. And now when we look at, again, overall, the number of women that are included in these trials, we think about 14% overall, though we think 14% is the goal for disease, is what we think disease prevalence is, but the trials actually represent less than 10%. So again, we're really not, the trial results are really not applicable to a lot of our patients. So the question is, are there less women in the trials because there are just less women with disease? Or is there something more that we're missing these patients? And are the trial results, again, applicable to the real world? So why do we think there are so few women in the amyloid trials? Well, certainly historically, and history not so long in amyloid, but this was considered a male predominant disease. And we know that women can present differently and often have a even later referral for imaging or biopsy than men. And they're often labeled as, oh, this is just a HFpEF patient without looking at the underlying cause, or as hypertensive heart disease if they see ventricular hypertrophy. Women tend to have smaller LV cavities, less wall thickening, a higher frequency of preserved ejection fraction and higher ejection fractions overall, and a more common conduction system involvement and microvascular disease we see in women as well. Also, barriers to enrollment in clinical trials certainly could be at the patient level, not just who we're enrolling. Women often have family and childcare responsibilities, There are financial, socioeconomic barriers, and this certainly applies to all of our trials. We're often excluding elderly participants, which women in their 70s and 80s are not being included again in these trials. And there is no specific defined eligibility criteria for these clinical trials to push us to enroll more women in the trials. So, well, to talk about, are these current trials representative of the real world, we're going to look at the TAUS registry. So this is a multi-center international trial, which is just basically a registry where we're recording what happens as we develop better ways to find these patients and what is the natural history of disease. So just looking at the wild type patients, the average, again, males, females, the women tend to be a little bit older at the time of diagnosis, older at the age of symptom onset, have a higher ejection fraction, and a lower LV and diastolic diameter. We also see that a lot of these women tend to have more polyneuropathy. So these patients, again, present at a later age, have less severe cardiac impairment and more severe walking impairment. So all of these things may be contributing to, again, further diagnostic delay. Now, similarly, in the hereditary patients in the TAUS registry, the male patients were more likely to have symptoms of cardiac involvement and more severe cardiac manifestations. And that's in terms of BNP, in terms of wall thickness, and myocardial involvement, we know even in the hereditary patients was more frequent, we think, in the males. So are there biological characteristics where women are clearing the amyloid protein more? Are they inhibiting some type of infiltration in the myocardium? Is there something different here that, again, where there's a less severe disease presentation? So we know, again, women tend to have less left ventricular hypertrophy, a higher ejection fraction. That itself leads to later diagnosis, though their prognosis is not any different. The question is, do we need something else to help identify these patients? Should there be a lower cutoff value for LVH, right? And that raises suspicion of amyloidosis. So this is a study by the NAC Center in London as well, and the whole goal here was to characterize gender differences among patients with cardiac amyloidosis. And so there were about 1,000 patients. Female prevalence was higher in certain mutations, so the T60A and the V122I compared to the wild type. Wild type, again, is thought to be more male predominant. Similarly, we saw females that were older than the males. And when we look at the phenotype, the overall structural and functional phenotype was similar, but a worse phenotype in females. There were no differences in clinical phenotype with disease progression or prognosis. So again, here we need to utilize potentially, rather than normal LVH cutoffs, when we index for body size, that we get more accurately find these patients, and then we can diagnose them earlier, and it's more accurate prognostically as well. So this study in the European Heart Journal as well was a retrospective study looking specifically at men versus women in TTR cardiac amyloid. And what we did see is that women tended to have a much smaller stroke volume, smaller interventricular septal diameter, and their diagnostic delay, which we already know is too long for amyloid patients, was considerably longer. So we know that, again, current diagnostic thresholds may not accurately reflect the female disease patterns, and we need to find better ways for early detection in women. So this is a systematic literature review where we looked at a lot of the similar studies, and this included 4,600 patients, of which 791 were women. and looked at their echoes as well. And again, what we see when we do a systematic review is that women tended to have a lower interventricular septal thickness, lower posterior wall thickness, lower LV-EDD, and a higher ejection fraction. So again, when we're looking and thinking, oh, should we consider amyloid? Well, their LV wall thickness is not greater than 12. Maybe we're missing a lot of these patients because they can have amyloid even with wall thickness that's much lower. And again, should we be indexing for body surface area? Should we be looking more at stroke volume index? What is the right parameter here? Or are there other ways that we can pick up these patients earlier? So again, in summary, what we're seeing with women is that there is a later age at diagnosis, later diagnostic delay. They tend to have more HFpEF rather than HFrEF. We do see normal carpal tunnel, we see aortic stenosis, we see less hypertrophy. We do similarly see elevations in troponin, but even more elevations in BNP and NT-proBNP, a smaller LV cavity, a higher LV ejection fraction, less bone tracer uptake. So these patients present differently than men. So even though we do think there is probably, truthfully, a lower prevalence in women, we still have many women to find, diagnose, and treat, and that diagnostic delay that's contributing to worse prognosis is even more profound in our women. Sex differences in cardiac anatomy can be contributing to this diagnostic delay and this underrepresentation in our clinical trials. So there's certainly a point to trying to find these patients earlier.